Welcome to the Schizophrenia Instant Symposium presented by Johns Hopkins University School of Medicine at Psychiatry Care Live. You're tuned into a session called New Insights in Neurobiology and Management of Patients with Schizophrenia with my guest, Dr. Daniel Weinberger. My name is Glenn Treisman. I'm the Director of AIDS Psychiatry here and a Professor of Psychiatry and Behavioral Sciences at the Johns Hopkins University School of Medicine. I'm pleased to serve as Chair for the Psychiatry Care Live series. Today's session is a live interactive program that allows us to take questions in real time throughout this presentation. I can see you on this computer. I encourage you to send us your questions anytime during the program by typing in the box at the lower left-hand side of your screen. I'd now like to welcome Daniel Weinberger, Director and CEO of the Lieber Institute of Brain Development here at Johns Hopkins University School of Medicine, and Professor of Psychiatry, Neurology, Neuroscience, Human Genetics, and everything else at Johns Hopkins University School of Medicine. It's a great privilege to have Danny on. I've known him for a long time. He's an internationally recognized authority on genetics and pathogenesis of schizophrenia. It's truly a privilege and a treat to have him. Danny, thank you so much for being willing to do this. I know your days are incredibly full, and I've been to your lab, and I'd rather be there than here, even though it's your lab. So thanks for coming over. Thanks for doing this talk. I'm going to let you go ahead, and I'll interrupt you as much as possible.
Please. So first of all, Glenn, thanks for inviting me. I mean, I like being in my lab, but I think it's very important to have these kinds of communications, and I'm really happy to be a part of this. So let me start off. You had asked me to talk a little bit about some of the breaking developments in our understanding of the pathogenesis of schizophrenia and novel approaches to treatment. I thought what I'd do is sort of give you a survey of where we've been, where we are right now, and maybe where we're going.
That would be great.
So let me start with just a little bit of reminding you, our audience, where we have been in schizophrenia. And this is really to ask the question, at the end of the 20th century, what did we actually know about schizophrenia? What did we know? We had many, many theories. We had a lot of ideas. But what we basically knew was this. Diagnosis is based on subjective and nonspecific phenomena. Genes collectively account for most variance in risk in the general population. We knew this from family studies, twin studies, adoption studies. We knew that environmental adversity, particularly in early development, accounted for a small increase in risk. We knew that there were subtle deviations in childhood development that were associated with increased risk for schizophrenia. Many, many studies of the human brain based on anatomical studies early in the 20th century, and then more recently functional studies looking at cognitive function and a variety of neuroimaging technologies suggested that there was abnormal function of certain brain systems, particularly those related to frontal and temporal cortical circuitry. A century of looking at the brains of people who died of schizophrenia couldn't uncover any diagnostic or specific abnormalities. There were subtle, non-specific abnormalities in some studies that were very difficult to be very confident about. And then last but not least, we've known for 50 years now that anti-dopaminergic drugs have therapeutic actions. That's what we've known. Let me try to go through a few of these to give you a feeling for some of the information. From anatomical studies and many, many neuroimaging studies, we've come to appreciate that there are gross but nonspecific differences in brains of people with schizophrenia and normal subjects. And these have focused on many, many parts of the brain, but probably most consistently, the evidence has suggested in the prefrontal cortex, particularly the so-called dorsolateral prefrontal cortex, and areas of the temporal lobe around the hippocampal formation, depending on how you survey the schizophrenic brain, whether it be an MRI scan measuring the size of things, or you do molecular biology looking at markers of synapses in the brain, you tend to find subtle differences, phenomenological differences between patients with schizophrenia and normals in these brain regions. Nothing diagnostic, nothing pathognomonic, but this is fueled, evidence. This is evidence that, strictly speaking, normality is something that patients with schizophrenia's brains show deviation from. We've also known now that the best predictor of overall outcome and disability, social and vocational function in patients with schizophrenia are not the diagnostic symptoms of the illness. They're not hallucinations, delusions, thought disorganization. They're actually aspects of human cognitive function. This was a study we reported now almost 15 years ago in which we looked at identical twins both of whom had schizophrenia. And these were twins that were genetically identical, had the same parents, they both had the diagnosis, and they both received antipsychotic drugs. But as happens in many twin samples who share illness, the outcome of these twins was not identical. One might be working, another one never left the hospital, one might be in an aftercare program. We asked the question, what accounted for differences within a twin pair, two people as alike as any two people can be? What accounted for them not having the identical outcome? And the entire variance in their social and vocational function as measured on a rating scale was accounted for by basically cognitive differences between them. So this has been consistently observed in many subsequent studies. I'll get to that a little bit later in this discussion, but I just want to mention that as one of the things we've come to know about schizophrenia. The other thing we've come to know, and this is from many studies looking at how the brain works, not just how you perform on a cognitive test, but how your brain works when you're engaged in cognitive operations. These are so-called functional imaging studies. These are studies that look at, these were early on, these were PET studies. Now the sort of this gold standard of these functional magnetic resonance imaging studies, which are non-invasive. You sit in an MRI scanner, it's a little bit claustrophobic, it's kind of noisy, but there's no needles, there's nothing invasive about it. And you measure brain activity using changes in magnetic signals that come from your brain. These studies have shown repeatedly that the functional activity of patients with schizophrenia is different from the functional activity of normal subjects, including their healthy siblings, when they're engaged in cognitive operations. And generally speaking, the differences are most apparent in the frontal lobes of the brain. This is where most of the differences are. And depending on the paradigm, one can see the frontal lobe disengaged, which has been called hypofrontality, or in other paradigms, the frontal lobe is overengaged. We call this an untuned frontal cortical engagement response. It has to do with the dimensions and characteristics of the paradigm that's being used to engage the frontal lobe. But however it's engaged, it's not engaged normally.
Not normal.
It's not normal. There's
It's
some
either
problem.
spinning its wheels and can't get traction and working too hard,
Or it falls off
or
the
it just
treadmill.
quits.
That's right. That's exactly correct. And that's the way we think it is, by the way.
Right.
So the other thing we know, and this is from the landmark studies of Saul Snyder here at Johns Hopkins, we know that the clinical doses that we use for most antipsychotic drugs, certainly the traditional antipsychotic drugs, are strongly predicted by how firmly these drugs bind to D2 receptors in the brain. And this has been the main model for thinking about the role of anti-dopaminergic blockade as a therapeutic tool. This is not to say that we think that dopamine is necessarily the critical pathogenic event in the cause of schizophrenia, but it's a way that we can reduce the functional deviation in the brains of these patients. So this is pretty much what we've known. The other thing we've come to appreciate, again, not based on what we know from the diagnostic criteria, is that there is signs that the developmental trajectories of patients who develop the syndrome of schizophrenia in early adult life is somehow off track from very, very early in development. And there have been now many studies, generally from Scandinavian countries where they have these population registries. People can be followed all their lives for any time they go for a medical examination, any time they go into the hospital. These studies have found, without exception, that if you look at early classic neurological milestones, when you sit up, when you stand up, when you speak your first words,
right,
when you engage in social interactions, people who will develop the syndrome, the diagnostic characteristics of schizophrenia in early adult life are slightly off the norm of when the developmental milestones are achieved. So this was a study from Finland, but it's like many studies showing that the normal male stands on average at 9 months of age and has a population risk of 0.5% of manifesting schizophrenia in their lifetime in Finland. If you, as a child, stand 3 months later, the chances that you will have a schizophrenia syndrome as a young adult is increased twofold. Twofold. This is not to say that if you stand up at 12 months, which is one standard